Hey everybody, welcome back. Miss Calabrese here. So in today's video, we're going to be talking about the physiology associated with respiration. All right, so last time we mentioned that respiration is different from ventilation. That respiration is gas exchange across a membrane. So when we do external respiration, for example, so external respiration is the respiration that happens between your alveoli, so the gases that find their way into the alveoli, and the capillaries that are associated with the alveolar sacs. Right, so that's external respiration because that's gases coming in from the outside atmosphere and entering the bloodstream. Right, and the way that that works is essentially through diffusion. So if we look at the alveolus, which we can see in this drawing down here, so the alveolus is going to be full of oxygen. There will be other gases in there too, but you're breathing in that oxygen, and that oxygen is going to be in higher concentration in the alveolus than it is in the blood plasma. So remember that this blood is coming from your pulmonary arteries. This is deoxygenated blood, so it's got a low O2 content. And that means that this oxygen that's in the alveolus is going to want to flow down its gradient into, down its concentration gradient into the blood. And the opposite is going to happen for the carbon dioxide. So this blood here that's returning from the body has a high amount of CO2 compared to a lower amount in the alveolus, which means that's going to also flow down its concentration gradient back into the alveolus. So it's all just operating by a passive process of diffusion where both gases are moving across the membrane according to their concentration gradients. All right, so here's another way of looking at this so we can see what's happening to that oxygen once it passes into those capillaries. So we can see that the oxygen that you've inhaled into your alveolus is going to move across the capillary wall. So now we're in the blood plasma. But that oxygen isn't just going to stay in the blood plasma. Most of it is going to enter into a red blood cell. Right, so when it goes into a red blood cell, the oxygen itself is going to be attached to a hemoglobin molecule. And remember that we talked about hemoglobin way back when we discussed blood and how hemoglobin is a large quaternary protein. It's got four polypeptide subunits. Each one of those has a heme component with an iron, and that iron is going to help attract oxygen. Right, so each one of those hemoglobins can carry four different oxygen molecules. And when we oxygenate that, we refer to it as oxyhemoglobin. All right, so the way that carbon dioxide is transported in your blood is a little bit different. So instead of most of it being transported in a red blood cell by attaching itself to hemoglobin, we have some of it that just gets dissolved directly as a gas into the plasma. So as a gas into the plasma. But most of it is going to go through this process, which we can see here. We're going to walk you through this chemical reaction here. So if I breathe in CO2, or not breathe in, if my cells are creating CO2, and as a byproduct of cellular respiration, and they're releasing that CO2 into the tissues, CO2 diffuses into capillary beds, and now we've got CO2 in the plasma. Remember that plasma is mostly water, so now we've got this combination of carbon dioxide and water. Um, those are going to combine to form a substance called carbonic acid, which we can see here. This is carbonic acid. Carbonic acid then dissociates into two different ions. We've got a hydrogen ion and a bicarbonate ion. Okay, so these are the ions. This is how most carbon dioxide is going to be traveling through our bloodstream. So most of it is actually going to be in the form of this bicarbonate ion, and then we're also going to have some hydrogen ions that are created from the dissolution of this carbonic acid. So to just think about what an increased concentration of hydrogen ions does to a solution, and we'll talk about how that's regulated in a little bit. Right, so most of it, about 70% of the carbon dioxide, is carried in your bloodstream in the form of this bicarbonate ion. And then a rest, about a quarter of it, is going to be directly attached to the hemoglobin. However, it's not going to bind to the same sites on the hemoglobin that oxygen binds to, so it's not taking oxygen's place. but when it does bind to that hemoglobin, we call it carbaminohemoglobin. Okay. All right. So talking about internal respiration now. So remember, internal respiration is what's happening at the level of the tissues. So this is oxygen that's already been absorbed into the bloodstream. It's returned to the left heart. The left heart has pumped it everywhere in the body. As it goes through large arteries to small arteries to arterioles to capillary beds. Once it hits the capillaries, it's going to be ready to diffuse across the membrane. So if we can see here, this is a systemic capillary here. We've got the red blood cells in the capillary. Those red blood cells are holding on to oxygen by attaching it to the hemoglobin. But so we've got high concentrations of oxygen here in the capillary. We've got low concentrations of oxygen in the tissues. So these are tissue cells up here. So remember, those tissue cells are undergoing cellular respiration, which means they're using oxygen to convert glucose into ATP. And so as they're doing that, they're depleting their oxygen stores, which means we've got low concentration of oxygen in the tissues, high concentration in the bloodstream here. So oxygen is going to flow down its concentration gradient, leave the capillary, and go into the tissues. Right, and the opposite's going to happen to CO2. So these tissues, having done a whole bunch of cellular respiration, are creating a lot of CO2 as a byproduct of that respiration. That CO2 then is in high concentration in the tissues, low concentration in the capillary, so it's going to flow down its concentration gradient from the tissue cells to the capillaries. Right, and it doesn't take much change in partial pressures to get this to happen. So if we've got just a slight change in the partial pressure, excuse me, just a slight change in the partial pressures of these different gases is going to cause them to flow down that concentration gradient. All right, so quick look at the hemoglobin molecule just to remind you what it looks like. So I mentioned a really large protein here with 4 polypeptide subunits that are all bound together. Each one of those subunits is going to contain a heme group, and each one of those is going to be able to bind to an oxygen. All right, so when we bind all of these hemes to oxygen, if they're all bound, then we would consider that hemoglobin molecule to be fully saturated. So if it's capable of carrying 4 molecules of oxygen, um, and your oxygen concentration of your hemoglobin is usually between 95 and 98%. If it's any lower than 95, then you're considered to be hypoxic. All right. So hemoglobin likes to bind with oxygen, but there are some factors that can affect just how much it likes to bind with oxygen, and we refer to that as the affinity. So affinity is basically how much you like something. So different things that can affect the affinity of hemoglobin for oxygen are the partial pressure of oxygen, so how much oxygen there is. The pH also has an impact. Temperature has an impact. The type of hemoglobin we're talking about has an impact on how much it likes oxygen. We'll talk about that in a second. And then this last one here, BPG. So BPG is a byproduct of your metabolism that is released mostly in skeletal muscle cells. So when your skeletal muscles are doing a whole lot of activity, which means they're highly metabolically active, they're using a lot of oxygen, they're going to release this BPG, and that's going to attract or it's going to get the hemoglobin to let go of its oxygen so that the skeletal muscle cells can have it, essentially. All right, so let's look at some graphs of these different affinities here. So focus here on the x-axis here so we can see the partial pressure of oxygen, and on the y-axis, the percent saturation of hemoglobin. So down here at the bottom, the hemoglobin's only 10% saturated. Up here, we're 90% saturated. Right, so we can see that the partial pressure of oxygen in the atmosphere is going to have a lot to do with how much of that how much that hemoglobin is going to be attracted to oxygen. Right, so the more oxygen we have, the more attracted that hemoglobin is going to be to it. right? So we need high pressures of oxygen in order for the hemoglobin to be attracted to it, which kind of makes sense. Just the more oxygen there is, the more likely that hemoglobin is going to be able to grab onto it and hold onto it. Other things that affect that affinity. So here's the same graph. So we're still looking at the partial pressure of oxygen and the percent saturation of hemoglobin, but now we're looking at three different lines on this graph. And this is how, if we're looking at the same partial pressures, how this looks when we change the pH. So a normal blood pH of about 7.4, that's where our hemoglobin affinity is going to be. Now, if we increase the pH, if the blood gets a little bit alkaline, it's actually going to be, it's going to like oxygen even better, right? So it's going to have a higher affinity. The hemoglobin is going to have a higher affinity for oxygen at higher blood pHs. And then the opposite is going to be true if the blood gets a little bit acidic. So if we're down to 7.2, for example, the hemoglobin does not like oxygen as much if we're at an acidic pH. Right. Now look at that graph and look at how similar it looks to the graph here on the right. So in this graph here on the right, instead of looking at pH, we're looking at carbon dioxide levels in the blood and see how closely they mimic what the pH levels do. And that's because a high level of carbon dioxide in your blood makes your blood more acidic. So this high PCO2 really looks like a low pH, and the low CO2 really looks like a high pH. And that's essentially because the concentration of CO2 is going to be related to the pH of the blood. All right, here, so temperature is another thing that affects the affinity of hemoglobin for oxygen. So if we look at this here, your normal blood temperature of around 37 degrees is the black line. If the temperature gets too hot, so if you get a very high temperature, your blood is going to be less likely to want to hold on to that oxygen. And the opposite is true for very cold temperature. Um, and the way that I like to think about this is just say you're drinking soda that has dissolved carbon dioxide in it. So not referring to oxygen specifically here, but just the temperature of a liquid being able to hold on to a gas. A colder soda is going to hold more gas than a hot soda. So that temperature has an effect on hemoglobin's affinity for oxygen here as well. All right, and then this one last one that affects the affinity is the actual type of hemoglobin we're talking about. So it turns out fetal hemoglobin, so the hemoglobin that's circulating in a fetus's blood, is slightly different than maternal hemoglobin. And that fetal hemoglobin is going to have a higher affinity for oxygen. And that's really important because as that blood is going through the placenta and into the baby, we want the baby's blood cells, fetus's blood cells, to be able to grab onto that oxygen and take it away from the mother's blood cells, right? That's the whole point, is to get that fetal tissue some oxygen. All right, so a few questions here. What's external respiration? What's internal respiration? What is the oxygen carrying protein in blood? And how is most of the carbon dioxide carried in your blood? Right, and so there's your answers. External respiration is the gas exchange between the alveoli and the capillaries associated with the alveolar sacs. Internal respiration is gas exchange that happens between body systemic capillaries and body tissues. Most of the oxygen in your blood is going to be carried by the hemoglobin protein, and most of the carbon dioxide in your blood is going to be carried in the form of the bicarbonate ion. Okay, so how do we control our rates of respiration? So a little bit of terminology here first. So hyperpnea is an increased rate and depth of ventilation. And this is normal. So this is normal that would happen if you need to meet increased oxygen demand. So if, for example, you're going for a run, you have higher oxygen demands when you're running than when you're walking. So you would need to increase the rate and the depth of your ventilation, and that's totally normal. Hyperventilation is what's happening if your ventilation rates increase regardless of the oxygen level. So whether or not you need that extra oxygen or not, hyperventilation is when we increase the rate. And because of that increased rate of ventilation, it tends to lead to very low blood concentrations of carbon dioxide because you're exhaling so much excess CO2. Okay, so the main regulatory pathway here is through chemoreceptors. So you've got some peripheral chemoreceptors in your aorta and in your carotids that are measuring the amount of carbon dioxide, the amount of hydrogen ions, so the pH, and also oxygen levels in your blood. And those peripheral chemoreceptors are then going to send that information to the medulla oblongata, and the medulla oblongata is going to respond to changes in pH and carbon dioxide concentration. So long story short, carbon dioxide is actually the primary regulator for respiratory rates. So you would think it's oxygen because that's the thing that we want, but it's actually carbon dioxide that's regulating your respiratory rate. All right, so hypercapnia is high CO2 and hypocapnia is low CO2. Right, those terms again. All right, so looking at a feedback loop here for control of respiration. So let's say we're going to start here at the arterial blood CO2. So if we are got a lower pH or a higher amount of carbon dioxide or lower amount of oxygen in the blood, so that high CO2 level is going to trigger those chemoreceptors in the aorta and the carotid. So they're going to say, okay, the blood CO2 is too high, the pH is too low. So they're going to send that information to the medulla oblongata, to that dorsal respiratory group within the medulla oblongata, and that's going to send signals out to those effector muscles. So remember that the muscles that are encouraging inhalation are going to be your diaphragm and external intercostals. So we're going to trigger those to contract more forcefully, so we can get this hyperventilation that we need in order to blow off the excess CO2 that we have, so that we can increase our pH back to where it should be. Right. So as we blow off some of that CO2, our CO2 levels go back down to normal, our pH levels come back up to normal, and then we reset the negative feedback loop here. So we're back to normal respiration rates. Okay, a couple disorders associated with your respiratory system that you should have some familiarity with here. So first one's asthma. So asthma is, there are a few things that kind of characterize asthma. One is these hyperreactive airways. So remember that the bronchioles are lined with smooth muscle that's going to be very responsive to autonomic innervation. So autonomic tone going one way or another is going to either dilate those bronchioles or constrict those bronchioles. And then the other major factor here is inflammation. So as inflammation increases, we're going to trigger a lot of excess mucus production, and that's going to give you trouble breathing, essentially. So a lot of times asthma can be a result of an allergy process, so something inhaled in the atmosphere. Sometimes it can be triggered by emotion, so stress can trigger asthma. Um, so the ways that we would normally treat it are things like bronchodilators. So bronchodilators are things that are going to increase the diameter of the bronchioles. Usually those are sympathetic stimulators. So where they're stimulating the sympathetic nervous system to open those bronchioles, so you can get more airway, more diameter in those airways. All right. A couple other ones here. So emphysema. Emphysema usually characterized by the destruction of the alveolar walls. So a lot of times this is the end result of many years of cigarette smoking, where the alveolar walls begin to break apart. So instead of having many small alveoli, they tend to become larger because essentially the walls between them are breaking down. And as those walls between them break down, we have larger air spaces that you're just not able to fully exhale because you just cannot force all the air out of those larger spaces. And because you can't exhale, you're losing this elastic recoil. And so it takes a lot more effort, right? So you have to put in a lot of effort, muscular effort, in order to exhale. And so over many years of this condition, you can develop what's known as a barrel chest, meaning that the, the musculature surrounding the lungs becomes bigger, more robust, because it just takes a lot more effort to get those breaths out. Right. Chronic bronchitis is when we're getting an excessive secretion of bronchial mucus, usually as a result of some kind of inflammation that could be related to asthma, allergies, or infection. All right, and then lung cancer here. So lung cancer, this is the leading cause of cancer death. And one of the reasons it's the leading cause of cancer death is that it's usually not diagnosed until it's pretty far along. And you start having some of these more serious symptoms like, the spitting up of blood and the extreme chest pain and things like that. So by the time it's progressed to that point, it's not usually as treatable as it would have been if it was caught early on. All right, and then pneumonia is an acute infection of the lower respiratory tract. So this is where small bronchioles and alveoli become inflamed, and it can be caused by a lot of different things. So bacterial pneumonia, viral pneumonia, fungal pneumonia. There's lots of different agents that can cause this kind of infection. Okay, so looking at an X-ray here, so we can see a normal patient's lungs in the picture on the left, all that kind of clear area, the black area, that's you're seeing air in the lungs. The patient on the right, the pneumonia patient, definitely has a pneumonia in that right lung, and you can see where it's kind of clouding up the lung, and you're not able to get oxygen in the parts of the tissue that are all clouded there. Okay, and then tuberculosis. So tuberculosis is an infection caused by bacterium, Mycobacterium tuberculosis. So it's very infectious, very contagious disease. And basically it's going to attract a lot of white blood cells to the lung tissue. So we're going to attract a whole bunch of neutrophils and macrophages that are going to try to eat the bacteria. Um, and then that is going to cause some secondary effects of inflammation by trying to trigger the phagocytosis of the bacteria. So symptoms, fatigue, weight loss, obviously cough, low fever, and then the hemoptysis, which usually doesn't develop until later stages of the disease. Okay, and then acute mountain sickness. So we've mentioned this one before, I believe. We talked about what happens if you go into areas of high altitude, what happens to the oxygen concentration in your bloodstream. So as you go higher in altitude, there's less oxygen available. So the concentration of oxygen in the atmosphere is going to be less available for you to be able to breathe in. Which means you can have these results of being basically hypoxic, so a little nauseated, can cause you vomiting, fatigue, drowsiness, things like that. So it's because you don't have enough oxygen in the bloodstream. And your body will work around this given enough time. So usually acute mountain sickness happens when you've just recently gotten to a level of high altitude, or if you're at extremely high altitudes. But over time, your body will correct the imbalance by the kidneys producing EPO, which is erythropoietin. That erythropoietin will travel to the bone marrow and encourage increased red blood cell production. And the more red blood cells let us make better use of what little available oxygen there is. Okay, so just a quick note on the embryonic development of the lung tissue. So the development of your lungs begins at about 4 weeks gestation, so pretty early on, although they don't quite look like lungs yet. They're just kind of these little buds of tissue that will eventually develop into lungs. So it's not until somewhere between 16 and 24 weeks gestation that you start to develop those type 2 alveolar cells. And remember, those type 2 alveolar cells were important for the production of surfactant, which is the substance that allows you to expand your lungs. All right, so yeah, from 24 weeks onward, then you should have plenty of type 2 alveolar cells producing a whole bunch of surfactant. And by the time you reach about 8 months gestation, usually there's enough surfactant to achieve compliance of the lungs so that they're able to fill and contract and do their normal work without totally collapsing. And then those fetal lungs, even if they are compliant and they're making enough surfactant, they're still going to be filled with fluid until birth. So essentially, a lot of what assists in that is just the pressure through the birth canal puts pressure on the thoracic cage, which causes the fluid that's filling those lungs to be coughed out. All right, last few questions here. What's the primary gas controlling your ventilation rate? Define hypoxia, hypocapnia, and hypercapnia. What's the effect of high altitude on the body? And what will the body do in response to that high altitude? Okay, and there's your answer. So the primary gas controlling ventilation is carbon dioxide. Hypoxia is low oxygen, hypocapnia is low carbon dioxide, and hypercapnia is high CO2. The effect of high altitude on the body is AMS, or acute mountain sickness. And the body responds by the kidneys releasing EPO, erythropoietin, which will trigger increased production of red blood cells. All right, so I hope that was helpful. Let me know if you have any questions.